In Module 3, we talked about the impact of traumatic experiences and responses. Now we need to discuss how to identify the individual trauma-related needs of the people with IDD and their caregivers. Again, the first step is screening and assessment. There are different paths that may lead to trauma-informed treatment. Sometimes the trauma that the person experienced is known. Other times, a person may present with behavior challenges or changes without recognition of trauma history or contribution. Systematic trauma screening and assessment can be helpful, especially when the trauma history is unknown. Given the known risk for trauma exposure for people with IDD, as we discussed in Module 1, a brief trauma screen is recommended when people with IDD and caregivers present with problems. Providers should consistently use a screening tool to identify a person's trauma history and traumatic stress responses, including sleeping, eating, and coping, and to direct referrals for treatment. Providers should share the results of trauma screening with the team as appropriate. It is important to maintain confidentiality. The worker and team should develop a plan regarding how the results of the screening will guide decision-making and planning for safety and well-being. Agencies and organizations can also collect information about trauma and its impact on families served, and use this aggregate information to develop policies, supports, and other resources. IDD may impact a person's ability to communicate trauma history verbally. Many people with IDD have communication limitations. In such cases, it is extremely important to slow down speech, use simple language, present one concept at a time, and integrate the use of visual testing materials as much as possible, such as photographs, drawings, and visual scales. It is important to be able to attend to nonverbal forms of communication with people with IDD. For example, if a person raises their voice, becomes more fidgety, or seems increasingly anxious when asked certain questions, this may be a better indicator of a trauma response than whether they endure specific symptoms. It is important to do a careful assessment of functioning continuously, in conjunction with assessing symptoms related to the traumatic experience. When the person's ability to communicate is impaired, it is important that a wide range of caregivers be considered, in addition to the person with IDD, as possible supports through the assessment and treatment process. These could include parents and guardians, and occupational personnel with whom the person feels comfortable, and who can communicate well with the person. It is important that caregivers receive training on the type of behavior changes, such as hypervigilance or avoidance, that may be associated with trauma exposure, so they may recognize symptoms in people with disabilities. Trauma screenings are often administered by frontline workers, such as service coordinators or caseworkers, to determine a person's trauma history and related symptoms. Screening for abuse and traumatic stress may include an interview with the person, the primary caregiver, or another trusted person. A person-centered approach allows identification of cultural, socioeconomic, and religious factors defining the person's values and problem-solving strategies. Standardized trauma screening tools may need to be adapted for people with IDD. For example, communication limitations of the person may hinder use of the standardized instruments and require adaptations. The purpose of screening is to identify those who need further assessment. A positive screen may result in referral for more complete assessment and treatment. Visit the International Society for Traumatic Stress Studies for a listing of screening and assessment tools for children and adults. While these assessments aren't specific to people with IDD, they may be able to be adapted for some people with IDD. Screening tools for trauma and traumatic stress in people with IDD have been developed, although they are not widely used in the United States by mental health or IDD providers. It is our hope that this training will encourage you and other service providers to consider adopting these or similar screening tools in your work. The Bangor Life Events Schedule for Intellectual Disabilities, or BLESSED, is a checklist of traumatic or stressful life events with self-report and caregiver report versions. It includes events that are more relevant to people with IDD than traditional life event checklists. It is freely available for clinical use and has been used in a number of research studies. The Lancaster and Northgate Trauma Scales, or LANCE, is a screening tool for emotional and behavioral symptoms associated with trauma or stress. It also has self-report and caregiver versions and is available by request from the first author, Dr. Wiggum. The Impact of Events Scale, Intellectual Disabilities, is an adaptation of the Impact of Events Scale Revised, originally developed for adults with typical development. The IES-ID is a self-report screening tool for adults with IDD and has promising psychometric properties. Caregivers of people with IDD are themselves at risk for trauma and mental health problems, and their conditions may impact their engagement in screening and reliability. Trauma can interfere with their ability to protect and support the people they support. When screening caregivers for traumatic stress, it may also be appropriate to ask other members of the family, such as parents or siblings. Examples of screening tools for caregivers include the Parent Emotional Reaction Questionnaire, which assesses stressful parental emotional reactions to the sexual abuse of their children, the Life Events Checklist, or the Trauma Recovery Scale. Following trauma screening is trauma assessment, a more in-depth exploration of the nature and severity of the traumatic events, the impact of those events, current trauma-related symptoms, and functional impairment. Trauma assessment is used if a person has a history of trauma and is currently displaying trauma symptoms. The assessment identifies the person's emotional and behavioral reactions to the trauma. Assessment results drive treatment planning and help determine whether a person might benefit from a trauma-specific treatment approach. The assessment is completed by a mental health provider, often using standardized assessment measures, as well as clinical interviews and observations, and may occur over 2 to 3 sessions. It is important to include caregivers in the assessment process as much as possible. This is also a good time to let caregivers know what the process is, for example, how the assessment drives the treatment planning, and how and at what point caregivers should be involved. Mental health providers then use the assessment results to determine the best course of treatment based on the person's identified needs. Trauma assessment is comprehensive and covers multiple domains, including basic demographics about the person, their family history, a complete and comprehensive trauma history, including events experienced or witnessed, a developmental history, an overview of the person's problems and symptoms. Assessments may use standardized clinical measures to assist in identifying the types and severity of symptoms the person is experiencing, as well as identify their unique risk and protective factors. An effective assessment will engage caregivers and incorporate their input. Assessment provides a structured framework to identify the clinical needs of the person. Assessments help to clarify what kind of treatment is most appropriate for the person, such as a trauma-informed treatment or other kinds of treatment. And as we've said, assessments may need to be adapted for people with IDD. In Module 3, we briefly discussed the symptoms of post-traumatic stress and some of the trauma and stress-related disorders. If you are a mental health professional responsible for assessing and diagnosing mental health disorders, you are likely familiar with either the Diagnostic and Statistical Manual of Mental Disorders 5, or DSM-5, or the International Classification of Disease 10, or ICD-10. These are the two primary classification systems used to identify and diagnose trauma-related mental health disorders. The DSM-5 is used primarily in psychological and psychiatric settings for diagnosing mental health disorders. The ICD-10 is primarily used in medical settings and includes both physical health and mental disorders. The mental health categories overlap significantly with the DSM-5. You may not be familiar with the Diagnostic Manual Intellectual Disabilities 2. The DMID-2 is an adaptation of the DSM-5 that was developed for diagnosing mental health disorders in people with IDD. It provides recommendations on how to modify the standard DSM criteria based on the level of ID, and we highly recommend this for mental health practitioners who work with people with ID. Here we provide some examples for how the DMID-2 adapts the DSM-5 diagnostic criteria for PTSD for people with IDD. For Criterion A, trauma exposure, the DMID-2 recommends considering a lower threshold for what might be considered traumatic based on the person's developmental level. In other words, what might be considered stressful for a person with typical development may be considered traumatic for a person with ID. For Criterion B1, distressing memories, providers should consider whether behavioral acting out or self-injury may be a symptom of distressing memories. For Criterion B2, recurrent dreams, the DMID emphasizes that trauma-related dreams may not have recognizable content, particularly for those with more severe cognitive impairment. For criterion B3, dissociative reactions, it is important to be aware that trauma-specific reenactments may be confused with symptoms of psychosis in adults with IDD. For criterion B4, distress related to internal or external trauma reminders may appear as disorganized or agitated behavior. For criterion C, avoidance of trauma cues, the threshold for what may activate a trauma reaction may lower and broaden, and may be reported as noncompliance for individuals unable to verbalize their reasons for avoidance. For criterion D1, the inability to recall details of the traumatic event may be associated with cognitive impairment and requires careful assessment. The DMID-2 has developed the DMID-2 workbook, a structured diagnostic approach to making accurate mental health diagnoses of people with IDD. It relies upon observable signs of mental illness and includes a mental health interview for caregivers. The structured approach and decision trees in the workbook help to identify and properly classify symptoms that might be easily overlooked or overshadowed. As we stated earlier, there are multiple providers involved in a person's life, and even more providers if that person has IDD and/or has a traumatic experience. These providers have many roles in the process of helping the person obtain IDD and trauma-informed services and treatment. Trauma-informed services refer to a broad array of support and care, including treatment that incorporates an understanding of the effects of trauma and aims to use practices that promote healing and resist re-traumatization. It may necessitate service providers to engage in advocacy on behalf of the person with IDD to ensure that trauma is considered and addressed, and increased case coordination to ensure that appropriate services are provided. Trauma-informed treatment refers to interventions that focus on addressing symptoms and responses to traumatic experiences. We will discuss both services and treatment in greater detail in this module. The key to developing effective IDD and trauma-informed recovery plans is to merge best practices from IDD-informed care, such as person-centered planning, with best practices in trauma-informed care, such as evidence-based trauma treatments. The goals of person-centered planning are to help the person meet desired life outcomes, have positive identity development, and to be happy. Person-centered practices are tools for meeting these goals. A number of person-centered planning tools have been used successfully in supporting individuals with disabilities, including PATH, Essential Lifestyle Planning, MAPS, and Personal Futures Planning. While they use different terms, they share common features. A family-centered approach includes the family and caregivers as active partners in the treatment and recovery of the person.